just got a couple of things to go through today. I don't know how many of you don't know me. My name's Nick Yang. I'm a paramedic over here at the hospital and run that ambulance for Beaver County. Most everyone in here, a lot of familiar faces. So today we want to talk about some common injuries that happen in the nursing home. All of us here today know how common head injuries are at the nursing home. Head injuries are serious injuries because they can lead to hypovolemic and neurogenic shock. We also must consider some precautions for when this happens to patients to prevent further spinal cord injury. Our goal is to stop major bleeding and package the patient for transport to the closest appropriate facility. Okay, so exactly what we mean by that, and what I want to stress to you guys. So, how many times have you been in a situation where you're looking down at a resident, and there's a big old blood pool here, and the resident is on the floor, and you're not really for sure. You know that there's blood, but you're really not for sure if there's other injuries. Have you ever been there? Walking at somebody's red, walk across somebody. Let me give you a scenario here. I want you all to imagine that it's lunchtime, and we have a resident. His name is Mr. Smith, and he's walking to the dining hall. And let's say he trips over his walker. Mr. Smith strikes the corner of his head on the table as he falls, and his head hits the concrete on the floor before he comes to rest. You hear the fall, and as you come around the corner, you see Mr. Smith lying in a pool of blood, and the whole right side of his head is actively bleeding. Okay? There are some of you here that may have already been a patient care provider in a situation such as this. When someone is profusely bleeding, our adrenaline gets to pumping, and sometimes we lose sight of being able to take care of the patient just because of the gruesomeness of the situation. I've been a paramedic for 7 years, and I've been in and out of a lot of nursing homes, and it's no joke. I can tell you this is the honest truth. To me, this is the best nursing home I've ever been in. Okay? And that's a testament to you guys. How many people are in here are CNAs? Really, CNAs? It's a hard skilled job over there, quite for sure. I was a CNA for several years, and that's how I started in my healthcare career. And I can definitely appreciate what you guys do as well as what everyone does. Okay? Head injuries resulting from blunt force trauma can bleed profusely. Controlling major bleeding should be a top priority. And we're going to go over some steps how to control major bleeding. Okay? And the reason head injuries can bleed so much is because there is so many arteries and veins that run to the head and through the scalp. And it carries very rich oxygenated blood. Okay? When your heart pumps, it supplies oxygenated blood through to the lungs, back to the heart, and the first place oxygenated blood goes to is to the brain. Okay? So anytime you have a head injury, it can be very bright, squirting, as we have like an artery bleed. So head injuries can be very, very serious. The first thing we have to do, we have to locate and examine the location from where they are bleeding. This, of course, is not as easy as it sounds when everything is covered in blood. We must locate the laceration, puncture, abrasion, etc. that is bleeding, and we need to measure it by millimeters in depth and length. Okay? Now, when we talk about assessing, like say Mr. Smith has a laceration above his right eyebrow, okay? When we talk about assessing that, you don't have to get a ruler out and say, okay, well, it's 3 millimeters by 2 millimeters a day. Okay? The goal here is to find where it's actually bleeding from. Okay? And once we found that location, then we can kind of take a guess. Okay, well, it's this long, and it's this deep. And a good way I do that, and even when I'm documenting it in run reports, is I compare it to something. Patient had a laceration approximately quarter size in length. To give it something more concrete to it that you can visualize. Okay. Okay. Once we have found where the head bleed is, the first thing we need to do to control the bleeding is to apply direct pressure to the wound. Okay? And the way we do this, and I'm going to show, Janice, can you come up here? Just have a seat right here. Okay, you always want to start out, let's say Janice has a cut above her left eye right here. And we got some bright squirting blood. Okay, bright squirting blood means it's probably an artery bleed. Okay, oozing blood usually means it's from a vein. So we want to take, of course, we're going to have body substance isolation precautions. And we're going to have our gloves on. If it's squirting blood, it's not a bad idea to have a face shield or something to cover your face with. Okay? And we're just going to take Janice here, and we're going to apply direct pressure to that wound. Okay? Now, once you're in this situation right here, you are not going to let go. Okay? And if you have blood start seeping through here, okay? If you have blood seeping through that, you can have the patient help you. I've done that millions of times in the ambulance. Here, hold this while I get hooked up. Okay, if you have blood seeping through here, you just want to take another one, another clean one, and keep applying pressure until it stops. Okay? Now, say she still is bleeding. Okay? And we've applied several fresh gauze pads, okay, and she's still bleeding. Well, now we want to make it like a permanent sort of pressure bandage, and I'm not going to wrap your head up, but
oh, please do.
well, this stuff sticks to your hair, and I don't want to do that. Okay, and how we do that, or how I do that, there's several ways to do it. You can take Curlex for one, but this is what I use, and this is Coban. And this is real stretchy, material, and of course really great for major bleeding. Okay? So, once we've done this here, with direct pressure, okay, 9 times out of 10, you're going to be able to control her bleeding. Okay? So we're going to pretend like we got your bleeding control. Okay. Patients may have wound to the extremities after a fall. The same rules apply here. If the bleeding continues to an extremity after elevation and direct pressure, we need to apply a tourniquet, okay? Now, I know that the nursing home may not have access to tourniquets, but we have them at the hospital, okay? And I wanted you guys to be aware of them because, you know, they're a life-saving, you know, tool that we have. All right. So use your arm. All right. So let's say if Susie's arm is bleeding, okay? We have a laceration right here, okay? And we've applied direct pressure to this wound, and it is still bleeding, okay? Now on extremity bleeding, the one thing we want to do is we want to raise her arm above the level of her heart, okay? And that will help slow the bleeding. Okay, and once we've done that, and we'll say we have this down, which is our sterile dressing. We've wrapped it with the Curlex, which I won't do. But we've wrapped it, but you guys can imagine what that will look like, okay? So you have the sterile dressing in here, and the wound, and it's all wrapped up, okay? So, you know, obviously, Susie's gonna have a real deep cut, okay, because she's still bleeding. Then we're gonna move to what we call a tourniquet. And these are called cat tourniquets or combat tourniquets. Okay? Our soldiers use these in Iraq and Afghanistan. Okay? Okay, so say her cut's right here. Okay? Okay, and according to the National Registry, emergency medical technicians, you want to take this 3 inches above the wound and bring this down. Okay? And you use this and you twist it until it gets real tight. I won't make that tight. We'll just do that right there. And you keep twisting this. Can everybody see? You keep twisting this until the bleeding stops. Okay? Now this is going to cause Susie to have severe pain. Okay? If she's bleeding here, this is not comfortable at all. But it is necessary. Okay? And the reason I wanted to show you guys these cat tourniquets is how many people in here live out of town? Anybody? Okay. These are something you can buy for $35. Okay. And in the event of an emergency, and you have somebody or yourself, and these are easy to apply to yourself, and somebody's actively bleeding profusely, and it's going to be 20 minutes before you can get them to the hospital, or it's going to be 20 minutes before the ambulance can get there, these will save their lives if you have one of these at home. Okay? Now, granted, if it happens at the nursing home, you know, we're right across the street. We should be there within a few minutes and be able to apply one of these for you guys. One other thing I wanted to bring up, you know, say that there's a natural disaster, okay, in Beaver. And we've had a tornado come through over here on the south side of town. Well, the ambulance is going to be out, and we don't know when we're coming back. And if you have residents down that are actively bleeding, you need to know how to use one of these. Because this will at least save, you know, it'll give you some time until somebody can get there, to get that patient where they need to go. Okay?
Got a question about one of those.
Okay?
A few months ago, back in August, I almost got my toe off with a lawnmower, and it ended up bleeding really bad. You know, after I left the hospital the first time, and I ended up back in the hospital, I had my foot elevated and everything. With one of those, how would you stop the bleeding on something like that?
Something like that, okay, like I said earlier, the first thing you wanna do is get your foot elevated and have somebody else apply direct pressure. And if that doesn't work, obviously getting cut by a lawnmower, that may not be
Yeah.
enough to get the bleeding under control.
You don't want to leave that arm for one thing there.
These can stay on for 5 hours. They've changed a lot of that. They found through research through Iraq and Afghanistan that these can actually stay on for up to 5 hours. On this, if that were to happen and you were by yourself, if it were me, I would wrap it around my ankle. Okay?
I just thought that might be something useful to know in case something like that ever
Yeah.
happens or whatever.
And these are, you know, for lack of better terms, they're idiot proof. And these will stop the bleeding. I don't care how profuse it is. It will shut it down, okay? And that really is our goal when it comes to bleeding wounds. Now, obviously, if somebody has head trauma, okay, we can't wrap one of these around their neck, but I'm talking about profuse extremity bleeding, okay? And if anybody wants one of these for home or anything, I have some extras coming. You just have to write a check to the hospital for it to be able to get one. Anytime we have, you know, a patient, you know, with profuse head bleeding or extremity bleeding, we always want to monitor their level of consciousness. Okay, we want to make sure they're alert to person, place, time, and event. Do they know who they are? Do they know where they are? Do they know what's going on around them? You know, those kind of questions. Okay, now, like I said, this is, without question, the nicest nursing home I've ever been in, okay? And that being said, you know, I've been in some not so nice nursing homes as well, okay? And one of the things I ran across in my career is going out to nursing homes, and they've had a patient that has had a real bad fall. And you get there, and you're in front of the patient, you're in front of the nursing staff, and the nursing staff says, well, Mr. Smith fell and he was bleeding, okay, and we got the bleeding to stop, but we put him back into bed. Okay. Anytime you have somebody with a major fall, don't move. Okay, don't put them back into bed. Don't put them back in their wheelchair. Okay. At this point, we want to start taking spinal precautions, because we want to prevent further injury to the neck and spinal cord. So if this patient, say Mr. Smith, has a fracture in his cervical spine, okay, and we start moving him without immobilizing him, well, we're going to cause, you know, possibly cause additional, you know, tissue swelling. We can cause that bone to move around, which could ultimately lead into paralysis for this patient if they're not already paralyzed. You know, we don't want to be the cause that caused Mr. Smith to be paralyzed. So we always want to take spinal precautions very, very seriously, because if we do, it'll lead to better patient outcomes later on. All right. Now, Janice has offered to let us spinal immobilize her. Okay, so Janice and Sam and Steven, you gotta come up for a minute. Now,
Take it up.
I know that this is something that, as far as spinal immobilizing someone, that the nursing home, probably is not going to do very often. But I just wanted you guys to see kind of what I'm talking about when I talk about spinal immobilization. Okay. Okay, now the three major components of the equipment we use to spinal immobilize somebody is a long spine board, a seat collar, a head box. Okay? And also all the information you ever want to know about spinal immobilization is on the National Registry for Emergency Medical Technicians. And there's a flow sheet for it and everything. Okay. Janice, I don't want you to have to lay on the floor, so can you just lay on the board itself?
You got that checked yet?
Well, yeah, we've done it before.
Bless you.
Yes, we've done this stuff before.
Yeah, but you never had to know how the blood starts.
I see. Okay. I'm gonna have sampled stable manualization of the C-spine, which is her head and the neck area, okay? Anytime we've had somebody that we suspect has had a serious head injury or has had an injury to the neck or back, this is what it needs to look like. We're gonna have somebody hold stable or manual stabilization, okay? And then
You're gonna get down there and can't get back up.
well, that's a possibility. Okay, and then we're gonna put a C color on her. You okay?
Yeah.
And then if you'll continue to hold these, so that Stephen, if you'll come to the left side and meet me in the middle. It's okay. Okay, talking.
Uh-oh,
It's perfect. Now that we have her pretty well secure on the backboard, we're going to put headlocks on her. And this just stabilizes her neck so she can't move it from side to side. Okay, so I want you guys to realize that this is what it looks like to completely spinal immobilize someone. Okay, and this is our goal when it comes to patients with possible spinal cord injury. Okay, is to get our patients like this, where everything's in line. Okay, and she cannot move her head and neck. Okay, and this prevents us from further tearing tissues or possibly, dislodging other bones. One thing I wanted to bring up here, before you put somebody on a backboard, okay, you always want to do this. Say, Janice, can you squeeze my hands? Okay, good. Can you wiggle your toes? Good. Okay? And so you want to do that actually before you put them on the backboard and then after you put them on the backboard. Okay? Now that we're here and we've come this far, by this time, as a care provider, fatigue can kind of start setting in because you've done a lot of things. So now's a good time, for yourself, just to take a breath, and reassess the situation. We want to go up here, and remember she had a laceration above her left eye, okay? Well, we want to check our interventions and make sure that laceration has stopped bleeding. And that we continue, to have controlled that bleeding. All right, you guys ready to get up off of there? There's a couple last things I want to talk about with you guys. I want to talk about hypovolemic and neurogenic shock. Hypovolemic shock is caused by blood loss. Your heart is a pump. And if the pump runs out of blood to pump, hypotension and hypovolemic shock ensues. Okay? Treatment for hypovolemic shock includes keeping your patient warm, giving your patient supplemental oxygen, okay, and Tammy's around or some of the RNs or LPNs. If it's going to be a while before the ambulance can get here, or say the natural disaster has occurred and you're going to have to sit on your patient for a couple hours, okay, starting an IV and giving warm normal saline to your patient, all those things are very appropriate. So in a nutshell there, say you have somebody that has a massive amount of blood loss. Like I said earlier, you come around the corner and the whole floor is covered in, We want to warm those patients up, okay, and we want to give them supplemental oxygen. Give them a non-rebreather if their O2 sat is 78%. Nobody ever was harmed by being on a non-rebreather, at least for 30, 45 minutes. Even in the ambulance, if we have real bad COPD patients with real low SpA02, we'll even run those folks on a non-rebreather for a few minutes and then change to nasal cannula. really the thing to stress there is to keep your patient warm. Put blankets on them, and, you know, if you have some hot packs, put some hot packs, under their armpit or in their growing area to keep them warm. Let's talk about neurogenic shock for just a moment. It's a less common form of shock, and it's associated with the autonomic nervous system. And the autonomic nervous system is what controls your involuntary muscle movements and your muscle tone. So what happens to neurogenic shock? Say you have, a massive amount of swelling on your spinal cord resulting from the fall. Well, there is a possibility that the swelling to the spinal cord or the brain can cause neurogenic shock. What happens is the swelling causes a blockage for your autonomic nervous system to send impulses to the rest of your body. Okay? So what results is you have a loss in your vascular resistance. So basically, everybody can see through that. It looks like the end of like a TP roll. Okay. Imagine this is like a regular vein or artery in your body. Well, without your autonomic nervous system, these veins and these arteries, they dilate because there's nothing to send impulses to it to be able to keep its tone, if that makes any sense. So basically they dilate without the autonomic nervous system, which means you have blood pooling because the amount of blood you had previously cannot fill the space anymore. And that's what causes neurogenic shock. All this information here as far as shock management, I basically, Wikipedia some of that. I have previous pretty good understanding. But if you want more information on that, neurogenic shock and hypovolemic shock, Wikipedia tells you just as much as any textbook will. Okay, head injuries can look and be very serious. Through controlling major bleeding, taking small precautions, and treating for shock, our patients will have significantly better outcomes. What we have discussed today is